I'm sure you can see a number of your colleagues there.
Yeah.
Dr. Gilbert and Dr. Frommer and a few of your colleagues, as well as the claims managers and everybody that are coming on. This is always a very popular seminar. You've done it a few times before.
Yes, I have.
Just by way of structure for today, if it's okay with everybody, I'm also going to introduce Lachlan White, who is the corporate relations manager for another company that we're associated with, which is called Insurance and Compensation Services, which is a software business. And Lachlan is going to just do a quick overview of a number of software solutions that we've got for, or that Insurance and Compensation Services have for the industry. Generally, we wait till about 5 past the hour before everybody gets going. Lachlan won't take any more than 3 or 4 minutes, so apologies for holding everybody up, but it is quite an exciting development in terms of doctor to client workflow management, as well as client to doctor. It's a new concept that Lachlan's very excited to talk to everybody about, and it's 4 past the hour, so I might just hand over to Lockie, but also before I do that, just say thank you again, Peter, for your commitment to the ongoing education of everybody in the industry. I know that your talk on hernias is very well received, so personally thank you from MAG. And I know that everyone's looking forward to your presentation. If you'd like to take questions at the end or throughout, please.
Whichever way. Yeah, whichever way.
Okay, so if anyone would like to ask a question, I don't think we need me to be the MC in any way. We'll just let questions come in. If you prefer to do it in the chat, I'm happy to pass those questions on as well. But look, I think we can get started, and I'm just very grateful that you've taken the time to do this presentation again for us, Peter. So I'll hand over to Lockie.
Mark, you've disabled screen sharing.
I always forget about the disabling. All right, back to you now, Lock.
Okay, so as Mark mentioned, Insurance and Compensation Services is we're delivering a range of software solutions to the personal insurance and personal injury industry. So our flagship ICS Connect platform, it delivers a class-leading workflow management system for all the personal injury stakeholders. We've got a range of other products, some telehealth solutions, AI claims management tools. We've got some client sector-specific platforms, and we're working on some integrated data and analytics tools. Additionally, we see the key benefits from the ICS platform as increasing operational efficiencies for stakeholders in the industry, providing a full management and oversight and reporting system, and giving clients, doctors, all stakeholders a secure and easy way of gathering their information. Key, functions of the platform, it's a full bookings and calendar integration, allowing stakeholders and specialists to interact directly. We provide a full workflow management solution with automated communications and person in charge allocation. And there's an integrated billings and payment system, which has API integrations with external accounting software to enable the quick and easy payments of specialists to facilitate the release of reports. Some of our stakeholder or sector-specific platforms include ICS Law Connect, which is a fully customizable platform to assist law firms in their information gathering processes. Law Connect provides modular service-based offerings with jurisdiction-specific communications and reminders. There are external API integrations with government portals for evidence retrieval, and we have external stakeholder logins and other features that assist law firms in their information gathering practices. ICS's Insurer Connect is our class-leading insurance software solution, and we're improving return to work outcomes and increasing work efficiencies. We provide modular service-based offerings, panel management functionality for your specialists, and a workflow and correspondence management system. Our ICS Doctor Connect, which may or may not be of interest to some participants today, allows independent doctors who may or may not work with a medical legal company to manage their reports for solicitors. It provides a dictation and report management process, full calendar integration, appointment reservations for specific clients, and an integrated telehealth solution to connect with claimants. Our final class...
And the payments platform there, look.
Yeah, so the payments platform allows doctors to ensure that they're paid before the report is released, to ensure that payment goes through smoothly. ICS Gov Connect is designed to allow government bodies at all levels to manage compensation claims at an excellent service standard, and include work communication solution to improve their return to work outcomes, and is a fully compliant document exchange platform. Our additional ICS solutions have a range of software tools which can assist personal industry clients to improve their efficiencies and stakeholder engagement. These include, but are really not limited to, AI tools. We've got claims leakage AI tools and financial calculations AI tools. We're working on some open source data analysis projects and some integrated telehealth solutions. With that, I don't want to take up too much of your time. I might pass back over to Mark to introduce Dr. Grossberg.
Thanks, Locke. I hope everyone can hear me there okay. I've got my new fancy headphones that I've stolen from my colleague next door. So, look, thanks for that, Locke. So over to you, Peter.
Okay. My name is Peter Grossberg. I'm an old-fashioned general surgeon where in the days that we trained, we did everything from top to bottom. But now, of course, everyone is very specialised, and I often tell the students that the definition of a super specialist is someone who knows more and more about less and less until he knows everything about nothing. And we're nearly there. So what I'd like to talk about today is abdominal pain. And obviously we would concentrate on hernias because that seems to be the commonest type of client that I would get for work care and for medical legal reports for independent law firms. So I'm just going to turn on the share screen. I'll go through the slides that I've written, and I'm happy to take questions anytime during the talk or at the end of the talk. So I'll just share the screen now. That should come up to there. Okay, shouldn't go on to the conclusion. Just a minor technical hitch. Now we're right. No.
Peter, if you scroll up to the top there.
Yep.
And then click on slide 1.
Okay.
And then you press that button again, that should work.
Okay, thank you very much. Okay, so what I'm going to talk about today is abdominal pain, hernia and work care. So the types of abdominal pain that we see, and you've got to remember that abdominal pain can be totally unrelated to any work situation. So abdominal pain can be due to inflammation, such as appendicitis, gallbladder disease or gastroenteritis, as well as a bowel obstruction and obviously cancer. And whilst these symptoms can occur at work, they are not considered to be work-related nor caused by the nature of the work, except in rare circumstances where known toxic conditions can cause documented conditions. And sometimes you'll get clients who'll be quite angry the fact that they develop the pains at work. They've got a bowel obstruction and they feel that it should be work-related. Now, most of these are totally not work-related. The other cause of abdominal pain, apart from inflammation, obviously, is referred pain. And this is something that's pretty important in the work care situation because work pain can frequently be transmitted pain from the lumbar or the thoracic regions, caused by degenerative disease of the spine. And we see lots and lots and lots of clients and patients who have back pain, which is due to degenerative disease, such as disc prolapse, or what we call osteoarthritis, or spinal stenosis, which is a narrowing of the spine. And this pain can refer to the abdomen, and usually you can tell the difference between this purely by taking a history and seeing where the pain is distributed to. And nearly always, if it's related to nerves, it'll be distributed in a very specific way. Industrial trauma obviously can cause abdominal pain, and this is clearly related to work. And the trauma might be blunt abdominal trauma, such as a client or a patient falling over a metal strut or a piece of timber. It can be penetrating trauma or trauma due to noxious substances such as fires and chemicals. These generally don't come into the report of a surgeon, but they still are work-related and can cause abdominal pain. Frequently, of course, this will require hospitalisation and surgical intervention, and it goes without saying that these should be covered by work care. Secondary problems, such as post-operative abdominal pain or the development of bowel obstructions as a result of the original accepted injury, should also be considered under work care. So if somebody presents with a bowel obstruction and they've had a previous accepted claim for some intra-abdominal problem that required an operation, it's more than reasonable that work care should cover that particular aspect. If, however, the patient presents as a bowel obstruction which is totally unrelated to anything that's happened at work, then I don't think it should be considered. So what's the cause of abdominal pain? Well, we can generally find the cause of the pain by taking a good history and a good examination. Whether or not the abdominal pain is accepted under work care, of course, is a legal and insurance decision based on probabilities and advice from the treating doctor. And there are many occasions where, as the treating doctor, we're not certain whether or not this can be work-related, and then it becomes a decision of negotiation between the insurance company, the lawyers, and the client. It's also very important to note that there are psychological causes of pain. And only yesterday I saw a patient who had significant pain in his neck and his arm, but a lot of it was related to anxiety, depression, and so there are psychological causes. And normally, if I see that this is a problem, not being a psychiatrist or a psychologist, I normally don't go into detail, and I will give a surgical opinion, and then I would suggest that they receive a psychological opinion. The commonest by far that we see, apart from back pain, of course, is the hernia. And that's the commonest work-related condition in general surgery. So what is a hernia and how is it related to work? Well, a hernia is a protrusion, bulge, or a projection of an organ or part of an organ through the body wall that is normally containing it. In the body, there are a number of potential holes, and when these holes get bigger, that's when a hernia develops. It's usually classified by its anatomical position. So if it's in the anterior abdominal wall, so anywhere from the left side to the right side and from the xiphisternum, which is the breastbone, down to the pubis, that's the anterior abdominal wall. And the commonest hernias there are what we call epigastric, which is just below the breastbone, umbilical, which is obviously the belly button area, the lateral abdominal wall, that's just on the edge of where you would expect to see the six-pack, where the longitudinal muscles meet the transverse muscles. And this is specifically called a Spigelian hernia. And then lastly, in the anterior abdominal wall is incisional. Anyone that's had an operation in the past, whether it's appendicitis or a gallbladder operation or an ulcer operation, or even following trauma, can develop what's known as an incisional hernia. So there is a protrusion of bowel or fat through the old incision. Even though it was sutured and repaired correctly 10 years ago, there's a potential area of weakness, and if that falls apart, there's an incisional hernia. There are rare hernias in the pelvic area, and they are called obturator and pelvic floor, and that's mainly in females, and it's usually not work-related. The most common hernia by far is the groin hernia, and that's what's called an inguinal, or some people call it inguinal hernia, and a fraction below it, perhaps 2 or 3 centimeters below, is a hernia called the femoral hernia, and they're both basically in the groin, and they are very similar. In the posterior abdominal wall, as distinct from the anterior abdominal wall, there is a hernia that is just in the back, just above the hip bone, and that's called a lumbar hernia. This is uncommon, but I've seen a number in the past 12 months that are work-related, and the patient normally presents with pain and a lump in the back. So what's the cause of abdominal hernias? Well, they're generally thought to occur as a result of a congenital situation. In other words, a child can be born and has a lump in the groin, and that's obviously a congenital hernia. Or he may in fact have a congenital hernia but really doesn't present itself until adult life. And the second type of hernia is the acquired hernia, and this is what we see mainly in work care practice or in general surgical practice. The acquired hernias are thought to be due to a weakening of the tissues of the abdominal wall, allowing the intra-abdominal organs to protrude through an area of weakness. The commonly accepted causes are due to a combination of increased intra-abdominal pressure and weakening of the tissues. And this, of course, comes about through work care, as many of the clients and patients that come to us say they do a lot of heavy physical work, such as construction work or working on the roads or things like that. And as a result of a particular activity, or as a result of working in that type of job for 5 years, 10 years, 20 years, they've developed a hernia. So the hernia can occur as a result of heavy physical work. A hernia can occur as a result of a chronic cough, urinary straining, chronic constipation. In other words, anything that raises your intra-abdominal pressure can cause a hernia. And that, of course, includes going to the gym. So we get frequently patients who have a hernia, they do heavy physical work, but they also go to the gym 3 times a week to keep fit. So it's often a difficult decision as to decide whether the hernia is work-related or is it related to social activity. And the last most uncommon cause of hernias is collagen diseases and malnutrition. And fortunately, we see very, very little of this. And that also includes vitamin deficiency and various medications. Okay, so what are the symptoms of a hernia? Well, the commonest symptoms is swelling. People will say, I was having a shower and I noticed a lump in my groin. Sometimes they say, it's not there all the time. When I lie down, it goes away. So these are intermittent hernias. And generally, these hernias are what we call reducible hernias. You lie down and the hernia disappears. You get up in the morning, stand up, walk around, have breakfast, and the lump appears. So that's a reducible hernia. Sometimes you can get a lump in the groin, which is irreducible. In other words, the client will say, this hernia never goes away. So that may be what's called an irreducible hernia. Now, the difficulty with an irreducible hernia is that this may become strangulated. And I'll talk a little bit about that in terms of what we do with hernias in a moment. The second commonest cause is abdominal pain or discomfort. And patients will often say, oh, if I cough, I need to put my hand on the groin so it doesn't hurt. Or they may just say, look, it doesn't really hurt, it's just uncomfortable and I'm aware of it, particularly if I do any heavy physical work. the pain is very rarely severe unless it's complicated. And if somebody comes into our consulting rooms and say, I've got a lump in the groin, it's agonizing, I'm always wondering whether there's something else going on. It can be agonizing if it strangulates, but hernias don't often strangulate. And then the last common symptom is nausea and vomiting, and that's nearly always related to an obstructed hernia. In other words, a loop of bowel comes out through the hole, can't come back again, and therefore the blood supply is compromised, and that patient will get severe pain, nausea and vomiting. And if you don't fix it, the bowel will perforate, and then you've got a patient with peritonitis, and that becomes a serious issue. So what do you see? Whenever we see patients, there are two things that we always consider: symptoms, which I've just gone over, and signs. So once you've done the symptoms and signs, almost always you'll be correct in your diagnosis, purely on clinical grounds, without the need for any investigations. So what are the signs of a hernia? Well, on standing up, there may be a visible lump in the right groin, left groin, umbilical area. In fact, this morning I did 4 hernias, 2 very large hernias in the umbilical region, one which was work-related and the other one wasn't. And I did 2 inguinal hernias, both of which were work-related. So, and they all complained of a lump that they could see. So the lump may be reducible, and we always try and reduce them, try and push them back. If they go back readily, then that's fine. If they don't go back readily, that patient needs a semi-emergency operation. The other sign is an obvious cough impulse. Some people will say, I never have a lump, but if I have a cough, it comes out and then it goes back again. And then lastly, of course, there's the lump that's always there that you can't reduce, and if you touch it, it's very painful. So what sorts of investigations do we need for a hernia? Well, despite the fact that we as sort of senior surgeons around the various hospitals teach that you don't need to do any investigations, almost all the young doctors that now graduate and who are in general practice will investigate them. And the investigation that almost all of them do is an ultrasound. And that is probably the worst investigation that you could do. But almost always they will come in with a lump in the groin and they'll say, my doctor's done an ultrasound and it shows I've got a hernia. And you feel like saying, oh, really? You've got a lump sticking out of your groin. Of course it's a hernia. So we try and dissuade general practitioners and young doctors from doing ultrasounds, because then you end up operating on an ultrasound diagnosed hernia, which may in fact not be there. Apart from the ultrasound, if that's negative, you may do a CT scan or an MRI. But once again, these are generally unnecessary. They are very, very good investigations, but they're unnecessary for a hernia. If a patient comes in with pain in the groin and clinically I can't find a hernia, then I think it is perfectly reasonable to do an ultrasound or a CT or an MRI. But what you've got to remember is that most of the time we can diagnose these very, very successfully. Okay. So the problem with the investigations is they'll not infrequently pick up an incidental anatomical abnormality, which has got absolutely nothing to do with the worker's symptoms. The worker then attributes all of his symptoms to the fact that the ultrasound said he's got an inguinal hernia. This may then lead to an operation, which in turn may lead to a complication, which in turn may make the worker totally unemployable and never work again. And in fact, one of the work care patients I saw yesterday was one of these patients who'd had a hernia repaired in 2016 and hasn't worked since because of chronic groin pain. So it is very, very important not to operate on an ultrasound diagnosed hernia, but to operate on someone who's got a clinical hernia. To treat a non-clinical based hernia is a dangerous situation, as I've said, as it will lead to surgery. And there are many doctors, surgeons, who will operate on someone who comes in with an ultrasound diagnosed hernia because the radiologist is adamant. He says, yes, on examination, this patient's got a hernia. And the fact that we can't feel it by examining them, standing them up, getting them to cough, raising their intra-abdominal pressure, suggests that this hernia is of no clinical significance. Ultrasounds are not reliable, and they frequently diagnose hernias, which are in fact not hernias, but are small lumps, almost always lipomas, which sit on the cord. That's the tube that leads down to the testicle. And it's very dangerous to operate on these people because you'll then have someone who you've got for life. I always tell the patients, when I can't find a hernia, or even when the hernia is very small, it is almost always possible to fix the hernia. And in this situation, we almost always use a mesh, but it is not always possible to fix the pain. I saw a patient on Tuesday who came in. He worked in a fiberglass factory, do quite a lot of heavy lifting, had pain in his left groin. The local doctor did an ultrasound and it quite clearly reported he has a hernia with a 5mm defect. Now, nobody's going to get pain with a 5mm defect. And so I had to explain to the patient that whilst he may have a hernia, which is unlikely, this is not what's causing his pain. And I could fix that hernia, but he would still end up having pain. And this is a very important work care situation because lots and lots of patients who come to us for assessments get operated on for hernias and then end up with chronic pain. When the history and the clinical findings do not suggest a hernia, despite the ultrasound report, and I've said this 5 times already, further investigations could be arranged because there are other causes of pain, such as muscle tears, muscular strain, degenerative disease of the hip joint, bursitis of the hip joint. And groin pain is a very common situation, both in the work care and in the sporting arena. And as most of you will know, a lot of the footballers have what they call groin strain. Fortunately, most of them don't have an operation, and the majority of them end up having what we call tendonitis, which is an inflammation of the tendons in the joint area. And this also can occur in the work situation. So what do you do about a hernia? A patient that comes in with a hernia that's sent to you for a work care assessment. First of all, you've got to work out, is the pain that they've got a cause caused by the hernia, or is it an incidental finding? Can the worker return to the workplace without danger? Nearly always, if someone comes to me with a hernia and they're not going to be operated on within the next 4 or 6 weeks, I almost always say you can continue working as long as you don't do any heavy physical work. So if they can do a desk-bound job or they can do a supervising type of job, it's quite safe to work. I'm aware that many of the companies, as soon as a client or one of their workers has a hernia, won't let them return to work for fear of being sued if something goes wrong. It's very rare for something to go wrong in someone who's got a hernia. The incidence of strangulation or obstruction of a hernia is 1% a year. So in 10 years, it might be 10%. So in other words, it's very, very small and it is quite safe to continue working. If you do have surgery, when can the worker return to part or full-time work? Well, in my practice, most of my hernias are done keyhole surgery, and I tell patients they can go back to work within 2 to 3 weeks. Most people can drive a car within a week and be back to work in 2 to 3 weeks. The majority of surgeons, however, do open hernias, which is the traditional way and which is obviously a very successful way of repairing hernias. That involves a cut in the groin, and in this situation we almost always say you shouldn't return to any heavy physical work for 6 weeks. What happens if there's a complication? Much as we think as surgeons that we are fantastic at operating, things go wrong. And the sort of things that go wrong are bleeding, infection, rejection of the mesh, recurrence of the hernia, and the big one that really bothers us is chronic groin pain. And these patients will almost never return to work. And there is a very significant incidence of groin pain in someone who's had a hernia repair. If you read the surgical literature, the incidence of groin pain, and that is chronic groin pain, which is disabling, is about 10%. If you read the psychological literature, they say it's about 45%. So you can see this is a major, major problem. And this is why you try not to operate on patients unless they have an obvious clinical hernia and unless it is giving them symptoms. So what happens if you do an ultrasound and the patient's got an obvious hernia on the right? Then that's fine. And incidentally, the ultrasonographer did an ultrasound on the other side and found they've got a left hernia as well as a right hernia. So what should you do? The right hernia is covered by work care because there's an obvious lump there. They do physical work. Work care has accepted it. What do you do about the other hernia? Well, because I do laparoscopic, which is keyhole surgery, my camera is in the umbilical, the belly button area. So if I swing the camera to the right, I can see the left side. If I swing the camera to the left, I can see the right side. So if I'm going to do a right hernia repair under work care, almost always I will repair the left hernia as well, even though it's asymptomatic and even though I accept the fact that they may have pain. It's still worth doing because invariably they will come back in a year, 2 years, 3 years' time and say, I've got a left-sided hernia, which in fact was there all along. Okay, so I talked about the complications, and very important is this chronic pain leading to visits to the psychiatrist, visits to the psychologist, and it really can be a major, major issue. You can also get testicular atrophy. In other words, the testicle can wither away because you've damaged the blood supply to the testicle, which is in the area of the hernia. Another important one is rejection of the mesh, and this is important because this relates very much to persistent pain. So persistent pain, rejection of the mesh are very closely linked. So the question comes, should you remove the mesh? If you remove the mesh, the patient is at increased risk of developing another hernia. So it becomes quite a difficult decision as to decide what to do. And if the mesh is rejected, you don't want to put in another mesh. You may have to modify the way you repair the hernia. It is of significant concern that the worker, as a result of the treatment of the hernia, which may or may not be work-related, develops a complication. And we see a number of patients who will never work again, and this is a tragedy. You have a 45-year-old patient who has chronic groin pain or has a complication from his hernia repair, never to work again. It becomes a social disaster, a family disaster, and this patient will be permanently unemployable and will end up on the dole, and that's a real tragedy. So I've mentioned before a couple of times this chronic pain syndrome, and that's a major issue, and almost always this should be a multiple disciplinary management. So it should involve a physician, a surgeon, a pain specialist, a psychiatrist, and or a psychologist. So you can see that this becomes a major issue in the work care situation. Often it'll end up back with the surgeon saying, please remove the mesh, this patient is in agony. And I always say to the patients, I can remove the mesh, but I will not guarantee you that the pain will go away, because almost always the pain is related to psychological causes, nerve causes, and only in a small way related to mesh causes. There are a number of surgeons in America who specialize in what's called triple neurectomy. And what they do is they see patients with chronic groin pain, and the only operation they do is they divide the nerves in the groin area, and there are 3 nerves in the groin area, and that's their whole practice, is dividing these nerves to try and anaesthetize the area and try and minimize the pain that they have in that area. So, in conclusion, it is generally accepted, although not proven, that all acquired hernias are related to increasing abdominal pressure and tissue weakness, often associated with physical activity. And if the history and physical findings do not match, then these patients shouldn't be operated on. If they do, it's almost always accepted under work care. It is interesting that weightlifters very rarely get hernias, and these guys are lifting 150, 200, 250 kilograms. So this is what makes us wary about stating always that the raising of the intra-abdominal pressure is the cause of the hernia. There are some scientists who believe it's the quality of the tissues in the area, and in particular a chemical called collagen, and the weakness of the collagen that allows a hole to develop and for patients to develop hernias. So hernias can also be associated with other comorbidities: smoking, collagen deficiencies, which I've just mentioned, vitamin D deficiency, malnutrition, and patients who are on steroids. So chronic cortisone for whatever reason, often medical causes, sometimes related to cancer. They have a weakness of the tissues and have a propensity for developing hernias. It must be accepted that there are many workers who have hernias that are totally asymptomatic and are unaware that they have a hernia. And I see many patients when I'm doing an abdominal examination, and I'll say, give me a cough, and I'll feel the lump, and I'll say, you've got a small hernia on the right. And I'll say, well, I didn't realise I had a hernia. I don't have any symptoms. So I obviously don't operate on those because they're asymptomatic, and all I'd be doing is giving them symptoms. So many of these patients are picked up on the ultrasound, and that's why we try and discourage people from having an ultrasound, because they're having an ultrasound for vague abdominal pain. All of a sudden somebody's diagnosed a hernia, and all of a sudden they're up for a hernia repair, which has got nothing to do with the abdominal pain that they've got. Which leads me to wondering, and I've been wondering this for years, should a physical worker, in other words, someone who's going to work on a construction site or even in a factory doing any heavy lifting, should they have a medical examination before they're employed? Because you know that patients frequently will have asymptomatic hernias, then they go to work, they get a pain in the groin, someone diagnoses a hernia, and automatically everyone says this hernia is related to physical activity. There are lots of people who have asymptomatic hernias. And I believe that any employer who wants their employees to do heavy physical work should get them to have a physical examination. And if in fact they find they've got a hernia, at least that's noted, that if they have symptoms later on, you can say, well, hang on, you had a hernia before you started working here. That's the end of my talk. I'm happy to take questions, and sometimes it can be very difficult, and sometimes people get very angry with us because we diagnose the hernia but we say it's not related. And this is particularly so in office workers. If you're sitting at a desk like we are all doing now, and you've got a hernia, and you go to your doctor and he says you've got a hernia, a lot of these patients will then claim it on work care. saying, oh, I've been doing excess hours and I lift up my computer, which weighs all of 1.8 kilograms, and I've now got a hernia. So it's sometimes a very difficult situation to decide who's got a hernia, and ultimately it's the insurance company or the lawyers that'll decide it based on what the doctor finds, even though the doctor doesn't believe it's related to physical activity. Okay, I'm happy to take any questions that people want to give me.
Peter, and if it's okay, I'd like to apologise to you for not adequately introducing you when I was removed from that office. I omitted to follow through and introduce you adequately. So if I could apologise to that to you for that, please.
I'm just an old-fashioned surgeon.
Well, I was going to note that you've done over 7,000 surgeries, but you've also done over 1,000 medico-legal reports for us. So you certainly know what you're talking about. But I'm sure everyone's taken the opportunity to look at your bio on your website and appreciate the esteem in which you are held. So I just thought I'd throw that in before everyone starts asking their questions.
Yep.
Can I ask a question? Donald Frommer. I've quite frequently had patients with divarication hernias, which are asymptomatic and don't require anything done and not related to physical effort. Do you find that they come across your desk very frequently?
Yes, thank you for bringing that up. I totally forgot about that. Divarication of the recti. I'll just turn that off. Divarication of the recti is a separation of the muscles in the midline. This is a common finding in pregnant women for obvious reasons, and can be found in workers. And what they'll say is they sat up in the morning and they found a great big lump in the anterior abdominal wall situated right there. And that's called divarication of the recti, as correctly stated. This is not a hernia. And we emphasize to them, this is not a hernia. Most of the time, they are, as you say, asymptomatic. They don't cause any symptoms. Patients are aware of them when they sit up. The other important thing to say is they should not be operated on, because very often they will recur, and they are not a hernia. It just purely means that the muscles have separated. Unfortunately, you can't fix it, and people say, oh, look, if I go to the gym and do abdominal exercises, will it go away? The answer is no, it won't.
Peter, Barry Gorbett here, and it seems a long time since the Alfred Hospital in Eric Turin, etc.
Yes, Barry, I remember you.
Well, thank you very much indeed for your presentation. In some jurisdictions, the test for work-relatedness is in fact a little more strict, and where work has to be the major or most significant factor in relation to a condition, which makes it really more than 50% of the problem. So apportionment of the multiple risks to determine that can be sometimes very challenging. And being male seems to be a particular risk in terms of many hernias, and maybe perhaps the fundamental risk. And so how do we go about perhaps apportioning where someone doesn't have a particularly physical job, but occasionally does a little bit of lifting, who smokes 20 cigarettes a day, who's got a bit of benign prostatic hypertrophy, etc., etc. How do we really define the most significant and major work-related factor?
You can't. Almost always these will end up being accepted because you can't. If they develop symptoms at work, even though they are a smoker and they might be on steroids and things like that, you can't apportion. I usually say, it's this famous word, on the balance of probabilities. So I say on the balance of probabilities, this is probably work-related. So I don't think you can attribute any percentage which is due to things. If they've had hernias before, and that's the important bit, they may have had a totally asymptomatic hernia before the index event, then that's a difference. And then I will almost always say this is not work-related.
I guess sometimes the other thing that advise employers or even insurers is that if there's a hospital waiting list of 12 to 18 months to get a thing fixed, such as a hernia, then maybe they should consider, without prejudice, assisting that being repaired now, so that that hernia doesn't progress and the person gets repaired.
I agree, because the employer will frequently say you can't return to work until the hernia is fixed. Yeah, no, I agree with you. I think in the interim, you fix the hernia, which is really not a big deal, not an expensive procedure, and then you can fight it out later on.
Thank you.
Hey, Mark.
A lovely pragmatic solution. Any other questions? Whilst we're waiting for someone else to ask a question, Peter, with your permission, we will distribute your presentation to all the registered participants, and with your permission, the recording as well, by request.
Yeah, no, that's fine. That's fine.
Thank you. Any other questions? Any other? I'm sure there's some.
I'm not sure what are most employees that employ workers to do heavy physical work. Do they require their workers to have a medical before they get employed?
Yep. Pre-medicals are common.
Yeah.
I'm not sure whether the hernia is part of that, or how you understand whether it is going to occur later on. Maybe look at they've got all this gene sequencing done now. We know everything about everything. Should be able to determine whether you're going to get a hernia, shouldn't you?
I don't think genetics does that, but certainly a physical examination before you employ someone would do that.
It's Donald Frommer again. Although this is not likely to become as a work care question, occasionally there are cases of people who have very large hiatus hernias, which can get a twisting or volvulus, which can give you quite bad epigastric pain. And sometimes I've been asked, has this anything to do with heavy work? And I've said no.
Yeah, well, I would entirely agree with that. I was going to say hiatus hernias, even if they're the ones where you can get a volvulus and you can get an obstruction because the hiatus is very large, that's a hernia between the diaphragm and the chest. These really cannot be considered as work-related. Even though they may have developed the twist at work, this is not a work-related. This is an intra-abdominal problem, which has nothing to do with physical work.
I hope you can hear me. This is Chris Young. There's a number of concepts. Good afternoon. There's a number of concepts with groin hernias which I find have got nothing to do with medicine and are just to do with lawyers and money. And yet it's very confusing because you're supposed to consent a patient properly, but I found it doesn't matter what you think, do or say as a surgeon, you can be damned if you do and damned if you don't. And so some of those issues are a single strenuous event versus recreational exposure, unilateral versus bilateral, the diagnosis, clinical versus ultrasound, watch and wait, your technique, mesh versus no mesh, how you fix a mesh, and consent. And you could have consented a person for 4 hours, and if they have pain, they'll say you weren't properly consented. And then issues of recurrence. And the last one, even the term pain, it's not enough to say you may have pain. You actually have to mention that they may have pain and or numbness. Peter, have you, before I go on, about anymore. Have you run? If you've done 1,000 reports, you must have run into the contradictory issues with those matters.
Oh, absolutely, absolutely, and there's no solution to that. And you know, we all do what we think is called informed consent, and I don't believe there is any such thing as informed consent. The patient has absolutely no idea what you're talking about when you're talking about possible complications. And all informed consent has to include the nature of the operation that you're doing and then the possible complications. Now, if you say to a patient that you might have an infection, they don't understand what that means, and it becomes a very difficult thing. And whether you do with mesh or without mesh, it becomes a major issue. And as you say, quite rightly, pain is an issue. It's lack of feeling in the region. And I always say to patients, wherever you make a cut, you're going to alter their sensation near that cut. And really, in all the reports that we do, I mean, fortunately, the majority of patients do well, and so there's not a problem. But the ones that we see with the chronic groin pain and the various complications, I mean, unfortunately, it doesn't matter what you tell them, you can't prevent certain things happening. I had a principal of a major law firm in Melbourne who came to me with bilateral hernias, and I examined him and I told him he's got bilateral hernias. And I started to go through this thing that I do with informed consent. And he said to me, don't talk rubbish, just do your job properly. I'm not interested in the complications. So, I mean, it can be very, very difficult. And he just said, do your job properly.
But you mentioned that while you're having a laparoscopic view, you will look at the contralateral side. Yep. If you look at the contralateral side and do a hernia and you hadn't told the patient you were doing it and then they got pain, or even if you did, they'll say that they weren't consented properly.
Yeah, no, but that's very true. But I would never look at the other side without getting permission and having that documented. I don't do hernias. How do I put it? I don't do them just because they're there. So if someone has not given consent for the other side, I wouldn't even look at the other side. It's interesting when you say to a patient, I think you might have a hernia on the other side, almost always they say, will you please have a look? And in that situation, I would always consent them. If I haven't consented them, even if there was a hernia there, I wouldn't do it. I've been caught out with this where I've done a procedure which I thought was entirely appropriate and the patient hadn't given permission. So I don't do it if I haven't given permission. So if I'm going to do both sides, I'll always make sure they consent for both sides.
I've currently got to write a report where the surgeon used glue and not tacks. And somebody's written that, oh, everyone uses tacks, you should only use tacks. Well, in fact, the majority of the literature would support that you're more likely to have neuralgia associated with tacks. I mean, I myself use absorber tacks, but I've just found that the medico-legal opinions from surgeons are absolutely contradictory rubbish, and they're just writing whatever supports the person, whether they're the patient or the defender. They're just writing things that support whichever side they're running for.
Well, I'm glad you asked that question because I, up until recently, was the biggest glue user in Victoria. So I glue all my meshes. I don't tack at all. I accept the fact that people tack and I don't have a problem with that, but you're right, they're more likely to get a neuralgia. You never get a neuralgia from glue. The glue dissolves within 3 months. And in fact, I was using Glue Brand, which is the brand that I use, and the company was so thrilled with me as they flew me to Italy and got me to tour their glue factory. So I use glue all the time. I don't have a problem with tacks, but I think for someone to write that you should use tacks instead of glue is quite wrong.
I'm not sure if you realise that your microphone's muted there, Chris.
The last thing is, well, I obviously see a lot of hernias. I've had an incredible number of patients in the last 2 years who are obsessed about mesh and think if I put mesh in, it's going to travel around their body and God knows tickle their brain. And so I've done a lot more one nylon darns, which you probably recall is the most common procedure done up to May 1992 until there was the conference in Sydney, and then Liechtenstein's became popular. But even though it's got a high recurrence, I've been finding that I've been doing a lot more, you know, modified Bassinis just because of this obsession with the word mesh.
Well, I'm glad you're doing that, because you're right. In fact, I met Liechtenstein, came down to the Alfred Hospital, and we met him in the 90s when he was promoting his mesh. And I also, in patients who are adamant that they do not want mesh, I do the figure of 8 nylon darn, or one nylon darn, exactly probably the same as you do. And what I've been doing recently is, on the odd occasion when a patient expresses some discomfort about a mesh, I'm really quite happy, because then I teach the registrar that you can actually do a nylon darn without the use of a mesh. And I think a nylon darns are good. As you say, it's a modified Bassini repair, and that's what we were taught when we were registrars. So, I mean, you know, Liechtenstein only came along in the 90s, and I graduated before the 90s.
Thank you.
Yeah, thanks for your questions, Chris, and thanks for your considered responses, Peter. We do have a question here from Kevin Barry, just a question. He says, in Victoria, if a claim is accepted for hernia, then a request for hernia repair is considered streamlined and does not require a medical review. Could this be a reason for the long-term complications with hernias when related to a workers' comp claim or injury? Do you believe this should be reviewed?
I'm not clear what the question is.
Kevin, if you're able to clarify that question, please just unmute and go ahead with the question. Kevin, are you there? Okay, so I don't think Kevin's microphone is working. So can you see the?
I'm just not sure. I wasn't clear what it was asking.
Okay, I'm just reading it verbatim. It says, in Victoria, if a claim is accepted for hernia, then a request for hernia repair is considered streamlined and it does not require a medical review, could this be a reason for the long-term complications with hernias when related to a workers' compensation claim or injury?
No, I wouldn't have thought so. The complications of hernias are very, very rare. They're very uncommon. They can occur in patients who have not had an operation, but they're pretty uncommon, and it's quite safe to wait several months if it's not convenient for the patient or not convenient for the surgeon to have the operation. No, complications are very uncommon. I mean, complications even in surgical repairs, despite the fact we talk about infection and chronic pain, it's still fairly uncommon. The majority of patients do pretty well.
Okay, thanks for the question, Kevin, and thank you for that answer, Peter. Just mindful of the time that it's just gone past the hour. If there are any final questions, please either type them in or unmute and ask the questions directly. But if there aren't any other questions, I'll close today and thank you again for your time, Peter. It's always an interesting area. There's been a lot of publicity about hernias and mesh recently. I'm sure that's probably a topic for another day, but with respect to workplace injuries, you certainly are one of Australia's experts, if not the expert. So thank you again for your time today. It's greatly appreciated.
Just as a final comment, the meshes that have been causing these big medico-legal problems, the meshes used in gynecology, and they're slightly different to what we use in hernia repair. But I do understand that patients are concerned about foreign bodies such as meshes.
Yep. Okay. Well, thanks again, Peter.
Okay.
Much appreciated. If there are any other questions, please feel free to reach out to me personally. I can pass them on to Peter. I'm sure he doesn't mind receiving questions directly from you. It's a great seminar. Always interesting. Just want to thank you again for your time today.
Okay.
Thanks, everybody. Bye for now.